Hi all, welcome to Board Quality Improvement Project on Trauma-Informed Care. I have with me today Lizzie, our lovely project lead and matron, and also with me Sidra, our lovely occupational therapist, and Tony and Emma are not here today. Tony is our sponsor, Emma our coach, and we are part of our membership. We are having Dr. Murphy, Dr. Radnam, our consultant, and Dr. Erin, who is our psychologist. We were supported on this project by Dr. Proctor and Dr. Campbell. Unfortunately, they're no more here. They're no more with us. What can I say about Board? Board is the only female ward within the medium secure forensic service, and as a result, we have service users at every stage of their recovery journey. This can make it difficult to have a set approach in how we care for our service user. We wanted to adopt a trauma-informed care approach when caring for the woman, many of whom enter the service having experienced severe emotional, physical trauma in their life. We didn't know how and where to start. We decided to do a quality improvement project that involved working collaboratively with our service user and the team. We spent a long time drilling down into our aim and made a few false starts before the project took hold. We forgot to record data, rushed into PDSA, and there were many bumps along the road. However, we are learning and collectively growing in confidence, and we work toward becoming a trauma-informed specialist service for women. For the next slide, I'm going to pass you to Lizzie.
Thank you. So as Hortense was saying, we started a project about 18 months ago and realised that Bow was a perfect ward for trauma-informed care because it is such a complex ward. We had some focus groups trying to think about what it is that makes Bow difficult. And on our fishbone here, you can see some of the themes. So one was identified as support. So the team felt there was a lack of support and inconsistent support. There's abuse from staff towards patients and between patients themselves. So that included racism, verbal abuse, physical abuse, self-harm, sexual abuse. That's physical and verbal. There was the needs of the patients themselves and sometimes the incessant needs and the emotional toll that took on staff. Communication was a big problem. So there's poor communication, things were muddled, often we lacked clarity. Staff weren't listening to each other, service users weren't listening to each other. And also one of the big things was about culture and attitudes within the staff team themselves. So people were challenging each other. There was accusations of bullying, people were feeling patronised, there's an unfriendly environment, a lot of cultural differences, and the ward dynamics themselves. And there's a little understanding of the impact that might have on staff and on service users. We created a humongous driver diagram looking at all these different themes, and unfortunately we couldn't fit it on a slide for you today. So we've just taken a few of the things from that. So looking at data collection, some of the ideas we had were around using comment slips for staff, DATEX, RIO, the safety cross, supervision, reflective practice, themes from the different staff discussions, and also mentee sessions. Some of the interventions we thought about were using SAV buddies for sexual violence. We toyed with the idea of introducing racism buddies for when there's racism on the ward, looking at bullying interventions, things like the HR processes, as well as trauma-informed care interventions. Support for staff included TRIM, training, and also having the police involved. And for the patients, we had PBS plans, formulations, pre-admission meetings where we looked at their trauma history, sexual safety plans, and just an awareness of the team dynamics and the impact that can have on patient care. We wanted it to be a co-produced project, so we collaborated with our service users. We've introduced a quality control board in the day area that has a list of all the incidents that happen with different categories, and we're really transparent about what happens on the ward and why, and we talk through with our service users what's going on. We've got a racism board, which we'll discuss a bit later, and it's a standing agenda item in the community meeting. Ward environment is still something we really want to work on, but it hasn't happened yet, so it's a work in progress, and we've got big ideas for how to improve. Looking at staff dynamics, we used Menti to get some anonymous feedback and dig deeper into the staff dynamics. We wanted to find out how bad things really were, and it became clear really quickly there's a lot of work to do with the staff team before we could start our patient-focused work. Some of the things we looked at was, do you feel traumatised working on Bow? 90% of people said sometimes, 10% said yes, and no one said no. So everyone felt traumatised by being there. Traumatizing each other as colleagues was also quite shocking. 50% said sometimes, 40% said yes, and only 10% felt that we weren't traumatizing each other as staff. So some of the interventions we did for that was every month we spent time getting to know each other. So we'd talk in our away days, we'd talk about our backgrounds, where we came from, our own staff stories. We did icebreakers, team bonding activities. We also introduced a weekly reflective practice. It was led by our psychologist, Erin. We did three-way meetings. We trialled out the use of a blue dot and a safety cross to indicate staff bullying, but it didn't seem too popular because people didn't want to be seen to putting those dots down for each other. However, we did use anonymous comment slips, and staff could fill those out at the end of each day, and they worked quite well. And we thought we'd keep checking in with Menti to see how things are improving over time. This shows our comment slips. So, and as you can see, things did get better and there were more good days being recorded. So staff could record different kinds of abuse that they might have experienced, as well as putting down comments and complaints about what had been going on that day. I'm going to next hand over to Sidra.
So, as Lizzie mentioned, one of the areas that we wanted to focus on was racism. So we recognized that this was a big kind of concern on our ward and a lot of staff were really unhappy. And we wanted to work collectively with our service users in order to kind of find ways to improve it and reduce the amount of racism happening on the ward. So we actually worked together to create the racism board with our service users, and we ensured that we highlighted the definition of racism. So we realized that there was a lot of education that needs to be done around racism and what the actual definition was and how it can be seen from different people. And then as part of that, we also wanted to highlight the consequences of racism, as we realized that there wasn't any sort of structure in place to tackle racism and what the pathway would look like. So we decided that all racist incidents will be day text. Racism was highlighted as a hate crime and will be reported to the police. Racist behavior will be recorded on patient record. We also had PC Harris come into our ward and speak to the patients individually if racism did occur, but also we had PC Harris also come into our community meetings. So when we noticed that there were more frequent grey dots, as you can see in the graph below, then we would actually raise this up again in a community meeting and discuss it as a wider community about what else we can do to tackle that. All racist behaviour was recorded, as mentioned, as a grey dot on our safety cross. We also, encourage staff to actually pull their alarm if they feel threatened by racist behaviour. And racist behaviour will be discussed in all ward rounds and impact on progression. Racist behaviour will impact Section 17 leave as well. This was all reflected on the racism board that we created, but we also wanted to make it quite positive and think about actually what can we do as a community and work together collectively to further reduce this. So we also made some kind of agreements as a ward about what we can do to further improve our knowledge as well. So we decided that we would agree to celebrate all celebrations and religious kind of cultural events. We would all learn about our different cultures. We would speak out if we do see racism. There was another agreement about treating people the way that we wanted to be treated, and also empowering our service users and also other staff that if they do recognize racism on the ward, to speak about it and raise it as well, be more vigilant about it. So these are kind of the change ideas that we came across, and we made sure that this was regularly discussed and we referred back to it in every community meeting. So it was kind of like a standing agenda. Another change idea that we can talk about, which Lizzie, if you can kindly go to the next slide, was we created the women's group. So we recognized that the women on our ward didn't have a safe space that talks about some of kind of the physical health concerns that they had and their sexual needs and their sexual health and other areas that they didn't feel so comfortable about discussing in cross-site groups. We decided to create a safe space on the ward for our service users to talk about some of these issues that they had or kind of topics that they want to learn more about regarding their physical and mental health. So we actually, as Lizzie mentioned, we wanted the service users involved as much as possible within the project. So we did a focus group, and these were the kind of areas that we felt that the service users want to talk more about. So some of the topics that we talked about within the group was body image, sexual health, healthy relationships, self-esteem. We also had sleep hygiene, and this was an MDT-led group, so all disciplines were actively involved in the group and took part in the session, and it was done in a really unstructured way to allow service users to feel as uncomfortable as possible. We also wanted to gain some feedback, so we got feedback throughout the group, and the service users reported that they really enjoyed the sessions and they wanted to continue that space. So our psychologist is also running the group on an ongoing basis, and it's a healthy relationships group because that's what the service users wanted to kind of keep going on about and keep talking about. And I think it's important to include service users' view and work collaboratively with them. So this was a very successful group, and we really wanted to share this with everyone. Thank you.
Hortense, you're on mute. Hortense, you're still on mute.
Our next step was to focus on of women physical health. Then through our women's group, we noticed that the physical health group didn't work, and we start to work collaboratively to make it less serious and bit more fun. And we incorporate specific aspects of physical health in the women's group. We celebrate World Menopause Day and Breast Cancer Day in collaborative with our patient, and it was so fun. And also we work collaboratively with other female services within the trust, because sometimes it's important to reach out and to co-work with other women service within the trust to understand and to learn from their service too. We force a closer link with other female women forensic service. Working with the local sexual health service outreach helps us because they are offered to provide some education section to our women as an enriched service, access smear test database on our behalf. They plan to attend to complete smear tests on site, and a specific referral form for contraceptive for mental health service user is now available. And also we have a named professional to link with. Can you move on for the next slide, Lizzie? And also, here in forensic, we didn't have the sanitary product, and we have to speak with the head of nursing, who finally agreed for us to have a sanitary product for our patient. And now all those are available within our service and also our ward for our patient. And moving forward, we have successfully tried a woman health form for Board and Gardner's Award using CTR acne, and we are now working with the RIO team to have this embedded into the RIO system. These are easy to track screening, date, over time, and between services. Can also link to establish RIO form for contraception. Referral have been made for outstanding mammogram because there's still a long waiting list for screening tests in the current climate. Free sanitary product are being supplied for the world, which is really good for our patients as they are enjoying it now. After a hard and fought battle, the hospital shop have now had sanitary product for female specific product on their shelf because there was something that was not available before. And we are liaising with the GP service to provide alternative self-administered smear tests for service users that prefer that option instead to going offsite. And also we have now a female GP accessible now.
Thank you everyone for tuning in and listening to us today. Thank you for your time. We would love to hear any comments or suggestions that you have, or if you have any questions for us. We also have a much longer presentation that we did in the Forensic Academic meeting, and if you'd like to see that presentation, please just let myself know or anyone on the team. There's email addresses there for myself and our coach, Emma. But thank you for your time today.
Thank you.